Welcome. Today we're going to speak about HIV. By the time you finish the session, I hope you'll be able to speak comfortably about the burden of HIV, the key risk factors for the disease, who is most affected by HIV, why HIV is so important, and what we've learned can be done to reduce the burden of HIV and AIDS. Let me begin with some vignettes. Henrietta was a 35-year-old Kenyan mother of 4 who lived in the city of Mombasa. Over the last 4 months, Henrietta was barely able to digest her food, had frequent bouts of diarrhea, and been losing weight. She worried about having AIDS. Henrietta went to a local clinic where she was tested and found to be HIV positive. She had been infected by her husband, who was a long-distance truck driver. John lived in South India and had full-blown AIDS. He was very sick and wondered how long it would be before he might die. Fortunately, the government had a new program for antiretroviral therapy. John was put on treatment, took his drugs faithfully, and before too long was feeling well and returned to a productive life. HIV has had an enormous impact on a number of societies, and an increasing array of measures have been taken to reduce that impact. However, despite progress, there remains on HIV a large unfinished agenda of new infections and of people who still need to be placed on treatment. Let's begin to explore this a little bit further with some background on HIV. HIV is a virus that can be spread in a number of ways. Let me ask Emily, how can HIV be transmitted?
It can be transmitted through sexual intercourse or also from a mother to her baby during childbirth or through breast milk, and also through needle sharing or blood transfusions or organ transplants.
Excellent answer. And in fact, let's look at a graphic that reiterates the points that Emily has so nicely articulated, that the roots of HIV transmission are unprotected sex, mother-to-child transmission, blood transfusion, or transplantation of infected tissue or organs. Let's now ask Yafet, what are some of the highest routes of transmission, since the risks of transmission vary?
Yeah, so the 2 highest routes are from blood transfusions with HIV-infected blood and also from needle sharing with someone who has HIV.
And let's look at a graphic that picks up on what Yafet has said and looks at the different ways in which you can be exposed to infection. The risk of blood transfusion is the highest of all, more than 9,000 for every 10,000 exposures. This is followed by the risks of receptive anal intercourse, and then the risks, as Yafet has pointed out, of needle sharing during injection drug use. There are other risks, as you can see, but they're substantially lower than the risks of these 3 types of exposures. The risk of transmission varies with these different routes. Let's also speak now for a minute about people who are most at risk of becoming infected with HIV. Traditionally, we've spoken of most at-risk groups, or groups engaging in high-risk behaviors, or most at-risk groups. But generally, people who are at most risk include, for example, commercial sex workers, injecting drug users, those engaging in sex with multiple partners, and certain occupational groups, especially occupational groups of men who are often distant from their partners because of their work, such as truck drivers, such as miners, or migrant men who have gone out to seek work, are generally also at high risk. The risks are also higher if you're an uncircumcised male. Females have higher biological risks than males, and having another sexually transmitted infection also increases your risk of becoming infected with HIV. The HIV virus is most infectious in the early stages of infection or in the later stages as the immune system gets weaker and weaker and weaker. Without treatment, about half of the infected people will have full-blown AIDS within 10 years. And it's also critical to understand that as your body becomes weaker and weaker from HIV, and your body becomes more and more immune compromised, you become more and more subject to what we call opportunistic infections. And some of these include, for example, tuberculosis, a cancer named Kaposi sarcoma, toxoplasmosis, and a disease called cryptococcal meningitis. The main routes of transmission vary by location. In the high-income countries, for example, the main routes of transmission initially were men who had sex, HIV-positive men who had sex with men. And this was similar in a few other countries, including partly, for example, in Brazil. There are other countries like those in the former Soviet Union in which needle sharing has played a very, very important role. In sub-Saharan Africa, the main route of transmission has been unprotected heterosexual sex. And in many of the countries in East and Southeast Asia, the main routes of transmission have had to do with men having unprotected sex with commercial sex workers, female commercial sex workers. The next graphic shows some basic facts about the burden of HIV. Among the most important of these is that there are 35 million people living in the world with HIV/AIDS, and in a sense we can expect that number to go up. In one way of speaking, this might be a good thing because it would reflect that fewer and fewer people are dying because of their being placed on antiretroviral therapy. On the other hand, of course, what we'd really like to do is see new infections go down, less need for people on therapy, and see this number go way down as well. There are about 1.5 million pregnant women living with HIV. A little less than 1% of the total adult population of the world, 15 to 49, is infected with HIV. There are about, in 2013, there were 1.5 million HIV deaths and just over 2 million new infections. And of those newly infected, over 10%, in fact, were children. When we look at the global distribution, we can see that the overwhelming share of HIV-infected people live in sub-Saharan Africa, but HIV can be found all over the world. Outside of sub-Saharan Africa, in fact, there are only a few countries with HIV prevalence over 1%, I should have said, including Haiti, Belize, Guyana, Suriname, Djibouti, and Thailand. Let's look for a second at the geographic spread, and this graphic shows you HIV prevalence by country, with the countries designated by color as being very highly affected, 15 to 28%, et cetera. And what we can do is look region by region. We see, in fact, the very highest rates of infection occur in southern Africa. The next highest rates occur in parts of southern and eastern Africa. And then we move on to parts of the former Soviet Union and other parts of Africa. And then we move to regions that have lower rates of prevalence of HIV, the share of the adult population which is infected, or countries on which there's relatively limited amounts of data. We also should understand that the number of new HIV infections peaked globally in 1999. The number of new infections among adults in low and middle income countries, in fact, fell by 30% between 2001 and 2012. Moreover, rates of HIV among adults declined by over 50% between 2001 and 2012 in 26 different low and middle income countries. On the other hand, there's less good news, particularly when we look at Eastern Europe and Central Asia, in which the rates of new infections, in fact, are continuing to grow. The Global Burden of Disease study in 2010, and I think the 2013 data will be very similar, indicated that HIV was the 6th leading cause of death for all age groups globally, but the 2nd leading cause of death in sub-Saharan Africa for all age groups. For people aged 15 to 49, however, in sub-Saharan Africa, HIV was the leading cause of death. It was the 5th leading cause of death globally, the 2nd for all age groups in sub-Saharan Africa, but again the 1st for people 15 to 49 in sub-Saharan Africa. Now, the global community has made a concerted effort, and many countries have made a very concerted effort as well, to try to ensure that everyone who's HIV infected can be placed on antiretroviral therapy. However, it's important to understand that earlier on in the epidemic, and as drugs first became available, there weren't enough drugs to go around. People were concerned with the price of drugs as well. And initially, the World Health Organization recommended that people be staged in their being placed on drugs and that their eligibility depend on what we call their CD4 cell count, or how immune compromised, in a sense, they were. Until very recently, the World Health Organization was recommending that people with a CD4 cell count of 350 or below be placed on treatment. Then it was revised in 2013 to a CD4 cell count of 500. And now, in fact, the World Health Organization is recommending that people be placed on treatment as soon as possible. If we use the 2013 criteria, then we could say that about 1/3 of the people who were eligible at that time have actually been placed on antiretroviral therapy. Now, we also want to highlight the exceptional health, social, and economic consequences of HIV. And most of you will be familiar with this, but it's important to highlight. One is HIV compromises your immune system, and as I mentioned, it therefore makes you more susceptible to other diseases and eventually death if you're untreated. 2, HIV can be transmitted from mothers to children. 3 is there's a term, HIV orphans. There are a substantial number of countries, particularly in sub-Saharan Africa, in which many children have been orphaned or left to live with family relatives because of the death of one or more of their parents due to HIV. HIV remains a highly stigmatized disease. It's less stigmatized than it was. Even in the United States, for example, in the early days of HIV, there was an enormous amount of stigma. There were children who were HIV positive because of blood transfusion who were not allowed by their community, for example, to go to school. And people with HIV continued to be shunned in many environments. This is a highly stigmatized disease. It's less stigmatized than before, but social stigma remains an enormously important issue with respect to HIV. There are the direct costs of treatment, and even though countries in the world have cooperated to try to do what they could to reduce the cost of antiretroviral therapy, it still represents an important share of the total costs of health in a substantial number of countries, particularly those that are relatively poor and have high rates of HIV prevalence. And it looks like it will be very difficult for some time to come for those poorer countries with high prevalence to be able to pay for all the treatment they need themselves. There are gigantic, forgive my use of such a colloquial term, economic consequences to families that have a member who suffers from HIV, as that person becomes less and less able to work as they become sicker until they hopefully can be put on treatment. And as other family members may also find it difficult to continue their work because of their need to care for the affected individual. And there have been a number of studies, none so conclusive and none so conclusive in retrospect, but which have all looked at and tried to examine the overall macroeconomic impact of HIV, particularly in societies in which a substantial number of adults have been infected. Now, as I mentioned, there are a number of countries that have made some important progress in reducing the number of new infections. I was very lucky to work on Cambodia, which has had a very impressive program, but at least earlier on as well, a number of countries, including Thailand and Uganda, about which some questions have been raised now, also made substantial progress in reducing the number of new infections. And when you look at those countries that have done so, there have been a number of factors that seem to be correlated with this. One is the exceptional importance of sustained political leadership. It's very hard to imagine how a country can address HIV effectively if leaders of these countries are unwilling or afraid or unable to speak about the epidemic and help enlighten society about the nature of this problem and what can be done to address it in ways that don't stigmatize the individuals who have it. It's obviously important to ensure that a broad range of society, because of the reach of HIV, understands the nature of the disease, appreciates the importance of the disease in society, destigmatizes the disease as well, and does what they can to help society address this as effectively, efficiently, as rapidly as possible. There are a lot of norms that are related to HIV. It's a delicate, sensitive issue that relates often to people's behaviors. And and it takes a lot of effort to try to change behaviors and to try to get societies to feel like some behaviors should not be stigmatized and some newer behaviors are actually kind of okay. Forgive my use of this term too. And these are clearly central to whether or not a country can make progress. Now, in addition, we also know that there's a range of behavioral, biological, and other efforts that are important if countries are going to make progress in reducing the epidemic. So let's look at them. And many of you will be familiar with a number of these already. People used to say at least that every epidemic is local. Even within countries, the epidemic in one place might be driven by injecting drug use, another place might be driven by men who have sex with men, and a third place might be driven by men having sex with female commercial sex workers. So it's really important to understand the nature of the epidemic, and that can only come about through good epidemic surveillance. It's important for society, as we talked about, to have good information and education about the epidemic. Voluntary counseling and testing must be offered, and offered regularly and in ways that are not threatening and that encourage people to come forward. We know that condoms, when used correctly and consistently, can reduce transmission of HIV. We know that HIV risks are enhanced if people have other sexually transmitted diseases. There are protocols for addressing maternal to child transmission, and more countries, I'm happy to say, are following those protocols. And some countries, such as Botswana, even though they're highly affected, have essentially reduced, almost eliminated maternal to child transmission. We know that men who are uncircumcised have substantially higher risks of becoming infected than men who are not circumcised, and therefore there are a number of programs of voluntary male medical circumcision. And we know that, again, consistent with some of these other efforts, we need to worry about the transmission from so-called high-risk groups to low-risk groups. And of course, today, there are very few places, happily, that don't screen their blood to try to be sure that they've completely eliminated transmission of HIV through the blood supply. It's also important to note the number of so-called structural interventions can also play an important role in reducing exposure to HIV. In South Africa, In South Africa, for example, many minors live in communities with other men, and some of these men frequent commercial sex workers, female commercial sex workers. Their exposure to HIV might be reduced if they could live with their families. There's also very good evidence, for example, that when young girls stay in school longer, it reduces their exposure to HIV as well. In addition to that, there are a number of programs going on with pre-exposure prophylaxis and selected number of groups in which this looks like it might turn out to be a cost-efficient approach. And of course, it's also really central to address what we call TB and HIV co-infection. Again, tuberculosis is an opportunistic infection that people can acquire when they're HIV positive and their immune system wanes. And there are a number of approaches that have been recommended to try to ensure that everybody with TB is tested for HIV and everybody with HIV is in fact tested for tuberculosis as well. Another part of the approach to address TB HIV co-infection effectively is called the 3 I's: infection control, isoniazid preventive therapy, and intensified case finding. Now, let me conclude this part by also saying that the world has set new targets for trying to address the HIV epidemic. And what we see is there are 3 parts to this. The hope is that, and the goal is that by 2020, 90% of the people with HIV will know their HIV status. 90% of those with HIV will be receiving antiretroviral therapy, and 90% of those treated will have a suppressed viral load. We know, in fact, that treating people suppresses viral loads if they're treated properly, and that can also contribute to reductions in new infection. You've now become more familiar with the ideas that HIV/AIDS causes an exceptional burden of disease. You've learned that the burden varies by region. You've learned that about the most important groups at risk of becoming infected with HIV, and you've seen the special importance of HIV, in fact, in sub-Saharan Africa. You also know that the routes of transmission vary by locale, and that women, young adults, I should also have said, and uncircumcised males have higher risks than others. Important progress has been made in a number of countries in reducing the new infections, and I always like to cite Cambodia as one example of that. There's also been very significant progress in placing people on antiretroviral therapy. On the other hand, there remains an important unfinished agenda in a world in which there are about 1.5 million deaths and about 2 million new infections each year, although that number of new infections is happily continuing to go down. In the next session, we'll speak about tuberculosis.